I know it's just after 2, and we'll, as I said earlier before we signed on, that higher education said that they had a very brief meeting and they would not run long at all. But higher education professors just probably not two of the same things when it comes to brevity. Let's open up in prayer. Senator Hatchett is on 4. Thank you.
Let us pray. Dear Heavenly Father, thank you for allowing us to gather here today. Thank you for keeping us safe, and please help us to do your will in this committee today and continue to put you first. In Jesus' name I pray, amen.
Thank you, Senator Hatchett. Just a heads up, so we have the Georgia Trauma Care Network Commission today, and Senate Bill 496. Tomorrow we're meeting at 1 o'clock tomorrow, and we'll have another bill by Senator Mullis from the Powerful Rules Committee. So first up today is the Georgia Trauma Care Network Commission. Liz Atkins and Dr. Dennis Ashley will come up. I think you may have some slides that we've been loading, and y'all just sort of give us a little background, and the floor is yours.
Thank you, Chairman Watson. Can you hear me okay? Can you hear me now? Okay. You should have, I see some of you looking at the annual report. So that, John, that's the annual report from the commission. And so I won't be going over that today. We have a slide set, and I don't know if you have the slides in your hands, but I think we'll be turning those into you if you don't have a copy. And but they'll be projected on the board here. So again, thanks for letting us come again. We're supposed to give an update to HHS once a year for the Trauma Commission, and we always enjoy coming to do that. I hope that you will look at this as I have some successes to tell you about today, and I hope that you will take great pride in these successes because they're your successes and our successes. We, as trauma docs and nurses, we save one life at a time. It's a slow process and an arduous process, but when we combine our legislators and the firepower behind that, we go to a different level. And so thus this marriage today between the commission and the legislation or legislators makes a huge difference. So with that being said, could I have the next slide, please?
May have handed that to you. Is that what that is? Sorry.
Never mind. Let's see here. I got you. Okay. I've broken the code here. Okay, so there may be some new members of the committee, so I always like to start a little bit with what is a trauma center. It seems sort of mundane, but you would be surprised at the questions that I get about ER and a trauma center, and aren't they all the same, and urgent cares and doctor's offices. Can't trauma be taken care of in all those places? And the answer is yes, but when we talk about a trauma center, we're talking about a little bit different kind of place. And first, you have to have what I call the room. This is our trauma room at the medical center. All other level 1 and level 2 trauma centers have a very similar room. It's used explicitly for trauma. You don't get in there if you have a heart attack or some other kind of disease. It's specifically for high-level trauma. And then you have to have the team, trauma surgeons, usually surgery residents. It's not a must, but in most level 1s, you see that. Respiratory therapists, radiology technologists, and so on, plus a whole slew of surgical specialists that involves plastic surgery, neurosurgery, orthopedic surgery. So you have to have the right room and the right team. And the goal is rapid resuscitation. This is that room after a trauma patient has rolled in, spent maybe 5 or 10 minutes in that room, receive some aggressive care, usually from an 11-member team. When the big red button or alarm goes off, it's like a NASCAR team. I think that's the best way to explain it. If you watch and see those teams, when the car comes down into the pit stop, they change the tires, the gas, to clean the windshield, and do all these things within about 15 seconds or so. And that's really how this 10 or 11-member team functions. And you can see it's sort of messy, but the goal was then to get you to the operating room within a few minutes to where we can stop the hemorrhage or take care of whatever the problem is. That is the difference between a standard emergency room or urgent care and a trauma center is really the NASCAR team approach, where you pride yourself in efficiency and speed to get the patient the care that they need. So the talk is now broken down into really four areas that I'll cover very quickly. First, I want to talk about quality. You as legislators give us money, and we need to know, you need to know, are we making a difference? Because you have to be accountable to all those patients out there that you see in your various regions. So we've invested a lot of money in what's called Trauma Quality Improvement Program. This is a program from the American College of Surgeons. It allows us to benchmark ourselves against 500 to 600 other trauma centers across the country. And we meet once a year in a huge meeting with about 1,600 representatives from those trauma centers. But then we're constantly looking at data throughout the year. And twice a year, we get a report that helps us see where we are in patients with shock, in patients with penetrating trauma, in patients with blunt trauma, and so on and so forth. It helps us look at complications such as kidney failure or infections and things like that. And this allows us to benchmark. So Georgia, when we started this process and the commission started working with the American College of Surgeons, there was really no state report. Each hospital would get their own report that was super top secret, and you only knew what your hospital was doing compared to the benchmark. But we worked with ACS and we said, we would like a Georgia Trauma Center report. In other words, if we could combine all our trauma centers into one and look at our averages against the United States, how would Georgia stack up? And they said, well, that's a great idea. We don't have a report. How about we work on one together? And working with the college, we actually developed that report, and we were able to come up with the Georgia Trauma Center report. So we can see how Georgia's trauma centers are comparing to all other trauma centers in the country. And in 16, the report was not good. You don't have to be a mathematician to quote Liz. She likes to say, everybody can know that red is bad. So if you see here, looking at our first state report, where you put all the trauma centers in one big box and you analyze them against the others in the country, you can see in every category measured, we were above average, and that was not a good thing. We were red. So if you look at patients with blunt mechanism of injury or penetrating or shock, we were not doing well. So we realized we had some heavy lifting to do. We needed to go to work as a state. With that being said, you can see from 15 to all the way out to 21. I won't read every box here. When we give you the slides, you can have that for your reference. But we realized we needed to make sure that the trauma centers were as well-equipped and well-trained as they need to be, and that they represented the designation that they had achieved, such as a 1, 2, or 3, and so on. So you see in the first American College of Surgeons, the far left there, verified trauma center was a level 2 trauma center. Then we got to 2016. We had the American College of Surgeons come in, and they examined or verified the first level 1 trauma center in Georgia. And we started, the commission realized that bringing in the American College of Surgeons for scrutiny, an outside agency, if you will, to look at our trauma centers and really to do a site visit and give them very stringent qualifications. We realized that this was really sort of the special sauce, if you will, that made the trauma centers better and allowed them to have better outcomes. And the Trauma Commission was so impressed with the process that we mandated by, I believe it's 2024, for funding for the trauma centers to receive funding from the Trauma Commission in the form of their readiness costs. They had to be verified by the American College of Surgeons. They had to pass the American College of Surgeons inspection. And you can see we didn't just drop this on the trauma centers overnight. This is a huge lift for the trauma centers. We've given them several years to do this, and each year another trauma center or two comes on, and we're going to be in good shape by 2024. With that being said, just the consultation part of it, where they come in and do a mock visit before they actually do the site visit, we found that to be incredibly helpful for the centers, and the commission paid for all that. So there was no cost to the trauma centers. And I'm happy to report that the 2021 report, we are black. Okay. Every category has come back down. So if you're looking for return on investment, if you're looking for quality and data-driven quality, you can see right there that we brought those diamonds back to the midline where they should be on our state report. So we feel good about the fact that we're moving in the right direction with our quality reports. On to rural Georgia. Rural health, Senator Burke already preempted as sort of like my spot man there, teed me up for this. So right here we go. So access to level 1, 2, and 3 trauma centers within an hour drive. If you're in yellow, you are within an hour of one of those trauma centers. And you can see we still have some gaps. The most predominant gaps are really sort of in that southeastern part of the state. So how do you fix that? And we've been working on that for some time. You're never going to be able in that area of the state to drop a level 1 trauma center in there. There's just not enough population or facilities that have that much firepower that we could do that. So there's other ways. Why don't we take the area that we have, and we've learned from the military, sort of adopted this program called March Pause. This is brand new. It really just happened here this year. March Pause from military civilian integration. And it's an acronym. It stands for Massive Hemorrhage Control, Airway Control. Look at the respirations, their circulation. In other words, are the patients in shock? Do they have a head injury? And then work on pain control, start antibiotic therapy quickly, take care of their wounds as best we can, and then splint, splint any long bone injuries and be thinking about transfer. And that's what if you think about it, that's what the military does. They move from an austere environment very quickly. They get to a little bit more sophisticated location, like an old MASH unit. And then before you know it, the soldier is in Germany at a very sophisticated hospital where they do all kind of various fancy surgeries. And we thought if we could take the hospitals that we have now and we could train them up, we could help them identify certain things. We could help them with resources, sort of like the military. Then we get those patients identified quickly, get care started, and then get them out of there to the higher level trauma centers. And that could be how we could solve those problems for our citizens that don't have access to a level 1 trauma center within an hour. And Emmanuel Medical Center, which is a level 4 trauma center, a rural trauma center, received a grant from the commission to develop a trauma care protocol adopted by the hospital and pre-hospital providers in rural Georgia. And you can see here they had their first meeting, and when I said this was hot and new, it is February 1st to 2nd of this year. And you can see the participants there. They kicked off their first meeting at Lake Blackshear. It was made up of various doctors, nurses, EMTs, paramedics, EMS representatives to try and figure out how to incorporate this into rural Georgia. This is really our pilot study. I won't read all the objectives, but some of them are describe the components of the March Pause algorithm, describe assessment, identify treatment of common life-threatening injuries, and the things that I've already pointed out to you. We want them to know how to do that and then move quickly. Really to bring that NASCAR team for what they can do into their community and then move quickly to transport those patients. And the ultimate goal is to reduce mortality from treatable causes of injury, which is usually either an airway problem or a bleeding problem. That's what takes you out the quickest. And that's where I think we can have our biggest impact. Now, this ties into the rural focused ACS consult visit. Remember when I told you when the Trauma Commission was working with ACS, the American College of Surgeons, we didn't have a state report for TQIP. Well, we went to them now. We said, our rural centers need help. You know, that we need to assess them. We need to find out what their challenges, what their barriers are, and we need to help them fix that. And we said, can you help us? And they said, well, that's a great idea, but we don't have a consult visit for level 3s and level 4s or just rural hospitals. We only really, for the most part, have a consultation visit for the 1s and 2s. But they said, why don't we work together like we did on the other, and let's develop it. So again, Georgia is leading the way. I'm extremely proud of this. Liz has really been in a lot of meetings with ACS, and we're leading the way now to where when we develop the consult visit from the American College of Surgeons for rural hospitals, they'll take that and use it for the rest of the country. So this is really a pilot project that'll start in South Georgia, but will then go nationally once they learn how to do it. And so Georgia's consult will be the first rural focused pilot project for the ACS. I'll get a little bit away from that. Basically, it just shows everything that it'll bring the sophistication of identifying challenges and identifying barriers for the rural hospitals the same way we do for 1s and 2s. All right, COVID impact. Has COVID impacted trauma? When we shut everything down and that first part of COVID, I thought, wow, things are I'm not gonna have anything to do. I'm just gonna be able to sit here and watch TV. Not that there's any sports on TV now, but maybe watch reruns. And that turned out not to be the case. If you look at our centers, our trauma centers, you see in yellow, it's 2020, in sort of blue-gray, 2019, pre-COVID. Our centers in the state saw about it's somewhere about 4.8%, somewhere between 4 and 5% increase in trauma patients during that time, even though we thought that the trauma would go down. Just to look at that a little bit differently here, we've got all the trauma centers listed A through S, and the ones going to the right there, you can see they actually had an increase in trauma, 5%, some of them all the way up to about 25 or so percent. So some pretty significant increases. And if there were a few trauma centers you see in yellow there that go to the left part of the graph, you can see they had a decrease in trauma. These were usually in the more rural area, which you might expect. They had a lot of COVID patients. They were inundated with that. Things were shut down. Businesses, not as much travel in those areas. At least that's my guess and Liz's guess. We don't really know for sure. But when you look at the overall picture, there was an increase across the state. And then this is just for your reference. Again, we'll make sure you have these slides. You may want to revert back to these for various meetings. The ones in yellow, you can see across the board. Again, just another way to depict it. You can see the increase in most of the trauma centers. And this ties into, this is just a snapshot of the Georgia Communicating Center, which allows hospitals to sort of look and see who's full and who's not. And this is just a snapshot in time. One day, looking at all the level 1 trauma centers, they're all red. They're all crowded. Some of them are diverting patients. Just to show you that COVID has had a definite impact because it takes resources for everything, and it's certainly hurt our ability to have trauma access. If you look at the same slide, the same point in time for the level 2s, you can see they're severe, and some of them are overcrowded. So again, the Georgia Communicating Center, we've sent recommendations to them from the Trauma Commission that we think this could be used statewide. I know it started as an Atlanta project from my understanding, but could be used statewide to help all hospitals sort of know what's going on with trauma and where to transfer patients, who's sort of hot and who's not. We, from the trauma standpoint, we didn't really need make any suggestions about funding. What we recommended was a few of the screens be changed to where we could see really who was on various types of specific trauma diversion and not. That's what was very helpful to the community. So they're looking at our recommendations. Hopefully those will be accepted soon. Okay, and I think probably getting toward the end here, looking at the data, I couldn't end if I didn't talk a little bit about finance. This is, you've seen this before. In other words, how much green does it take to be orange? That's a little bit acute sentence and title that really makes sense to the trauma community. Green is money. Orange is the color of the book that the American College of Surgeons has with all the guidelines in it and to be certified as a trauma center. So how much does it take to actually be certified? And this was presented at the American Association for Surgery of Trauma in 2018. It's been published. We've gained a lot of national attention over this. You can see for level 1 centers, it's about $10 million. For level 2s, it's about $5 million. The Trauma Center Association of America is taking this now, and they are, again, using Georgia data to take the survey that we use, which is very tightly controlled, very scientific, and they are doing a pilot project nationally with various level 1 trauma centers to get a pulse on the nation as far as these costs. What we didn't have back in 2016, we just got, I mean, literally, we're still analyzing the nuances of the data, but this just came out. Level 3s and level 4s, we didn't know the cost of those. We had some soft data, but none that I really trusted early because it didn't have enough centers in it. But now we've just done a very scrutinized report, just like we did for the 1s and 2s survey data that was very tightly controlled and audited. And it looks like the level 3s are going to fall out at about 1.7 million and the level 4s at 81,000. This is tremendously important to us and the American College of Surgeons and the Trauma Centers Association of America as we move forward, as we work to recruit other centers to come into the system, especially in that rural area. As we work to fund those areas that need rural centers, we have a better feel now of what they need, and we need to identify the barriers, and we'll sort of have the whole piece there. So in closing here, you can see we've worked hard over the years to try and narrow the gaps. You see, we still have a gap sort of in that southeastern part of the state, and we're working hard now with our grant and with our rural hospitals to develop that March pause, treat them as much as we can there quickly, but again, like a NASCAR team, get them to a higher level of care. You've seen this before. We've improved access. We used to be around, I know there's a lot of data on that slide, but if you look at the second line from the bottom, about 63% of patients, only 63% used to get to a trauma center. You can see that line's gone up to about 84, 85%. So we've increased access. Our mortality data, when we look at least critical, intermediate critical, or most critical, however you slice it, the red line is the trauma center line, and you can see that we do better at trauma centers versus non-trauma centers with saving lives. The only thing we haven't cracked yet, and we have some soft data on that, is time to definitive care. And what I mean by that is if you're hurt and you're in the ditch, how long does it take you to get to the trauma center? If you get to a rural hospital and you're treated there and then you're transported on to the trauma center, we call that definitive care. How long does that piece take? The data that we have so far, this is the first time we've actually been able to see it. I don't want you to put this in your head and memorize it, because I'm not saying it's that great yet, just to be quite bluntly honest, but it's the first foray, if you will. It's the start. You can see there, we analyzed 7,000 patients. Looking at the median time for all level centers was about 55 minutes to get from the ditch to some type trauma center when you're transported immediately there. And down in yellow, you see 76.2%. That means we were able to analyze 76%. In other words, we had complete data sets on 76% of the data. So that number is probably fairly accurate. I don't exactly know yet what regions, and we don't have it granular. That's just sort of a global number for the state. And then if you look over, the number I really, really, really want is that number from when you're in the ditch, you go to a non-trauma center, and then you're transported from there to the trauma center. How long does that whole process take? It looks like it's just under 6 hours. But again, you see in yellow, 15.7%. We were only able to collect data or analyze data with complete data sets, only about 15% of the data. So we're trying to figure out how to get better data and how to get those data points. All the computer systems don't necessarily talk together between the states, and that's been a bit of a challenge, but that's sort of the holy grail and the next thing we want to work on. So just to end with a patient story here, this just happened. This was in South Georgia, down around the Cordele area, a van carrying a lot of workers. I think it was 18, Liz, is that right? And another vehicle collided and crashed and rolled. You see there was a response from ground EMS as well as air EMS. The rural level 3 trauma center at CRISP was involved. One patient was taken there, or a few of the patients was taken there that they could handle. One or two of the other patients had to be carried by ground EMS. They couldn't land on the scene there. They had to be carried by ground EMS to CRISP, where then there was a smooth transition from ground to air. And then they went on to the level 1 trauma center. A very, very nice response. So it's those kind of responses that we're working for. We want to make the whole system work, because we know one day, that could be us out there in that field or on that road. So the smoother the process is, the better. We've made a lot of improvements. We've got a lot of areas still to improve on. I'd like to thank our partners. This is not just the Trauma Commission. There's a lot of folks in the state that work together to make this happen. I get to present it and Liz gets to present it, but there's hundreds of people behind us that do all the work. We're just sort of the messengers here, and all those folks deserve your appreciation. So I'll stop there, and thanks for your attention and your time.
Sure. If you wouldn't mind if we have some questions, number 8. Okay.
Thank you so much, Dr. Ashley. I have a soft spot for the Trauma Commission because I work with the Medical Reserve Corps for the Medical Association, which is under your organization. And just thinking back, former State Senator Cecil Staten started this whole thing back in 2007. We passed legislation because he had a personal traumatic episode and realized that there was a hole in the system at that time. And I think in 2012 is when we started requiring a report back to the legislature. So we've definitely made great progress since that. My question for you is about the coordinating center. Is that the same thing that we created 2 years ago at the beginning of COVID, when we were trying to transfer people, figure out which hospitals were full and which ones had capacity? And now that's morphed into other uses that are beneficial? Is that the same thing?
Yeah, if
Yeah,
you're okay
please
with
go
that.
ahead.
Yeah, I've been working closely with them because what Dr. Ashley mentioned about the enhancements is right now, that was primarily for the Atlanta area during that crisis. And I believe it actually initiated first with Grady's flood, which took out a majority of their capacity. So, but what we think is that if we can get the hospitals using that during COVID, it wasn't uncommon for a hospital to call multiple hospitals and spend hours trying to get patients who are bleeding to death in the emergency room out. So we think if we can make some enhancements to that so that a hospital could just go right on and what you just saw where it's all red, we could at least delineate a trauma transfer diversion status. So you're not even going to waste time calling that center if they're on trauma. Now it's up to us. If everybody's on trauma transfer, we have to work internally to say, okay, who's open and who's open for business. We don't want to send patients to Tennessee and Alabama and Florida because we have to figure out some way to absorb that. That's up to us. But yes, that's exactly the center that, yeah.
Any other questions, Senator Kennedy?
Thank you, Mr. Chairman. Not a question, just a comment. I want to say, I want to thank Dr. Ashley and both of you for the work that y'all done here, and mention with some personal pride that Dr. Ashley is at Atrium Health and Medical Center in Macon. And I've had the pleasure of working with him before. And just thank you for the work that y'all are doing. It's going to benefit all of Georgia, but particularly the rural areas that really need it. And so, Dr. Ashley, it's great to see you. Thank you for being here.
Thank you.
Number 12 here. Okay.
Great to have you here. And I think we talked about this a little bit up in Rome when I know you're up there at that, but the super speeding, and I might have missed the start of the meeting. How is that being allocated now? Do you know?
I may be able to answer that one. So the super speeder, as of year before last, was 100% super speeder money goes to the trauma center. As you know, listen, the legislature was guilty of using super speeder money for other issues relating to healthcare, but it is now 100% funded. And so you got to remember too, we voted on fireworks. Yeah. So, there's no discretion with the fireworks because we did a constitutional amendment with that. So I think it's like 50-50 with firefighters and 50 goes to trauma center. I think that's maybe $1 million or so, or $900,000
Correct,
or so,
yes.
something like that. So, all of the super speeder money goes to trauma commission. That's due there, and all of the fireworks does too.
Right, that was intent, and I just want to make sure we've been following.
Yeah, got you. Well, I think I think everybody around HHS is 100% on that one. So, but having said that, the governor has done that and we have followed through with that. Thank you. Senator Hart.
Thank you, Mr. Chair. In that same vein, looking on page 9, so the allocations do they go to the commission that then allocates out? I mean, this lists all of the dollar amounts, by the levels. And I'm just following the flow of the money, I guess is what I'm asking. How does that work?
That may be a question for me. So the funding comes into the commission from the legislature. And then we are guided by Senate Bill 60, which is now in code. It says where the money has to go, in the sense that some has to go into readiness costs, some has to go into uncompensated care, and so on and so forth. And so then we get into various equations of how all that happens. And I'm happy to, what you're looking at there, I think, I can't see the page, but it looks like the sheet that shows what each trauma center got and so on. So then we break that down. EMS gets approximately 15 to 20% of the funding. The trauma centers and trauma physicians get the rest. And then some of it's for operations and new projects and things like this grant for Emmanuel and so on and so forth. Then once it gets into those various silos and buckets, there's various committees and things like from EMS that with state representation that decides how they need to spend that money. In other words, what should it go for? And then it has to be voted on and approved by the commission. Then the money for the trauma centers, some of that's broken down into those various silos as well. And we have very complex equations that the trauma centers have to send in data. We have audits to make sure that it's correct. And then the money goes in depending on what their allocation is based on the formulas. And I'm happy to sit down and go through that. It's pretty sophisticated. It's very interesting to sit and watch. Okay.
Thank you, Senator Hart. And thank you. Any other questions? We're all good. Thanks so much for being here. Always, over the years, this has really, progressed, and we certainly applaud y'all for what y'all have done. Thank you.
Thank you.
both
We
so much.
appreciate it.
Okay.
Thank you.
All right, so next on the agenda is our own Senator Burke with SB 496. And Senator Burke, you can do it from your seat. You can go to the podium. You can do it from the witness places up there, but whatever you want to do. All right, that sounds good. Is that 3?
3, yes.
3. Bring that up close to you. And I don't think we had anybody to sign up. Did we? Nobody sign up. So I think you're it. The floor is yours.
Thank you, Mr. Chairman. Senate Bill 496, and we're working off of the LC 339035S. So that's 9035S.
Let's be clear on that. Just we all have there are 2 bills in there, so I want to make sure we're looking at the right one. Everybody clear on that one? No questions? LC 339035S. Thanks.
Right. And just a little background, in your packet, the Department of Public Health provided this 1-pager on maternal mortality. And I won't spend much time on it other than down at the bottom where the Mortality Review Committee has made recommendations on trying to lower our maternal mortality rate. The top one there that is highlighted is that Georgia should mandate an autopsy be performed on all pregnancy associated deaths. And the reason for that is the number of patients that charts were reviewed and they weren't able to determine the cause of death. So there's a significant number of those every year. And it's hard for us to improve on these cases when we don't know what the cause was. So the autopsy obviously is the scientific way to determine cause of deaths. And so the charge to me was, when I found this out, is how do we do that? What would be our process? And so we talked with, of course, the committee itself, and then we talked to the medical examiners folks and the public health. And from those conversations comes Senate Bill 496. And just a quick summary, we all know that when deaths occur related to crime, that an autopsy is required. And those cases have what they call a coroner case, and then there's a process for how that happens. And so what this bill contemplates is that if a pregnant female or someone who was pregnant within the last 365 days, so that's 1 year postpartum, if that death occurs, then a coroner's case is declared, and the circumstances are reviewed. And if it's obvious what the cause of death is, then nothing happens. But if it's not obvious, then those cases are referred, instead of going to the crime lab, which was where it would go if there was a criminal case, these cases would be referred to the perinatal centers. And the perinatal centers, and again, DPH provided a map. There's already a perinatal center in each part of our state. And so those perinatal centers have the capacity, the pathologists that can do a clinical autopsy. And so those cases will be referred to the perinatal center, and they will do the case. Now, that's what this bill does, is it just develops that process so that those maternal deaths will have, as best we can, have an autopsy done when it's uncertain what the cause of death. The other change in the bill that is not related to maternal deaths, it's just clarifying that if the patient has been seen by a physician within the last 180 days, those cases are handled differently when they're not. And that was something the medical examiner wanted to make sure. It's called unattended deaths. We're just clearing up that definition of what is an unattended death. So that's on lines 35 to 38. Be glad to answer questions. I know the folks from public health are here, and if there's any concerns or questions, I'll be glad to answer them.
Certainly. I mean, and it sort of goes back to the Trauma Commission. If we don't have data, we can't analyze it and we can't address it. So, I mean, I think that's sort of the whole point of it. I mean, you know, it's not an uncommon theme here. If we don't have the information or the data, then we're not going to be able to act. So that's what we're trying to do here. Senator Orrock, did you have a question?
Share to the author, and thanks for your long years in the trenches, Dr. Burke, on moving this subject matter forward and translating into policy. What is the significance of an unattended death, that designation, unattended death versus an attended death?
Well, again, because of the resources involved, you don't want to do an autopsy when it's not necessary. So all that is allowing somebody, if you have a physician that's seen you and they're willing to say, this patient died because of X, then we don't have to do an autopsy on those cases. And
So
so
it's bringing the physician into the room, if you will.
That's right.
Metaphorically speaking, and
they've
sourcing
always been in the
information.
room, but it wasn't clear exactly of when that gray area.
Right.
And
so
this
that-
just
I see.
uh,
And then the first sheet that you referenced shows clearly that, which was, I think, news to a lot of folks, myself included, of how many of the maternal deaths occur after the pregnancy ends, you know, with the birth, that massively, what, 80% of the deaths that we're having occur.
Yeah. And we,
Post-pregnancy in the-
I think one of our members brought that up when we were doing the postpartum extension of, you know, why
That's
did we
what-
need that long?
right,
And I think I made the case that
Yeah,
because so many deaths occurred during
Yeah,
that
and
time, but this gives a number and it's
this
a
is
better
it.
visual.
exactly. Thank you so much.
All right, any other questions?
Hmm.
Senator Walker?
Thank you, Mr. Chairman. Thank you for this good legislation. Chairman Burke, I do have a couple of questions on the part that we were just talking about, the 180 days prior. Was there any consideration to making that a year instead of 180 days? I mean, like myself, I have an annual physical. I have some medical conditions like a lot of overweight people my age do.
We can talk about that later.
So if I were to die of a heart attack outside of the 180 days, would my family be required for me to have an autopsy?
No,
Or
no, 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 no. This is, pregnancy related, but it's also forensic related. So, in other words, not everybody has to get an autopsy when you die. Even if you've not seen a doctor in 5 years, if you walk in and you're having classic heart attack symptoms and you fall over, nobody's gonna make you have an
okay,
autopsy. Okay,
that
so this is, again, giving
I meant
clarification
to ask you that
that
before
the
we got
the
here.
coroner's folks and the medical examiner's folks can look at a situation and say, okay, we've got data to say we know what happened. We don't need to send them to Atlanta
I got
for
you.
an autopsy.
Thank you. It's probably a very dumb question.
No,
No,
that was
no,
good
it's not.
question, good clarification. Thank you. Any others? So I'll be happy to recognize Senator Kirkpatrick.
The appropriate time, Mr. Chair, I recommend do pass on LC 339035S.
It is the appropriate time to have a second. Second, Senator Huffstetler. All right, any further discussion? Sure.
Line number 58, where they scratched out paragraph number 6 of subsection A, and they moved that to paragraph 5. Here. I don't know. These are the paragraphs they're talking about. I don't understand the change and didn't know if that was a scrivener's error, if that was on purpose.
I don't know that I can answer that without ledge councils.
Yeah, might have a little ledge counsel. She did raise her hand and so we'll call on her. Yes.
This is Betsy's work, but if you look at paragraph 5, 5 is for children. Paragraph 6 is. So logic is.
Okay. That makes sense to you, Senator Hatch?
Okay, so we're cleaning that up.
Cleaning it.
Okay, thank you. That makes sense.
All right, we appreciate the lawyerly
Yeah. conversation with the
input there.
lawyers.
We're getting insurance input, lawyerly input. We're rocking. That's good. All right, so I think that we're in the posture of LC 339035S has been a motion to do pass, and it was seconded. And is there any further discussion? No further discussion. All those, let's raise hands this time. All those in favor, raise your hand. I think I won't ask for no because that was unanimous. Okay, so thank you very much. So that passes, and by substitution, you're correct. I got reminded, do pass by substitution. Thank you so much. That's going to end today. Reminder tomorrow, 1 o'clock, and we have one bill at 1 o'clock, and look forward to seeing y'all again. Thank you.